Today's session is titled Critical Care Outside the ICU, a Rapid Response, and we are graced by a number of incredible expert panelists. Today we have Dr. Anna Crawford from Stanford Global Anesthesia, the Division of Global Health Equity, Dr. Nicholas Suarez from American British Cowdrey Medical Center in Mexico City, Mexico, Dr. Rodrigo Rubio from the American British Cowdrey Medical Center, Mexico City, Mexico, Sean Garvey, Crisis Resource Nurse from Stanford University, Dr. Al-Hassan Dati Mohammed from Aminu Kano Teaching Hospital in Nigeria, Dr. Freddie Ariza Cadena from the University del Valle, Colombia, Dr. R.J. Ramamurthy from Stanford University, Dr. Vanessa Mall, University of Zurich in Switzerland, Ali Sung, Crisis Resource Nurse from Stanford University, Kiara Stetson, ICU Nurse from Stanford University, Dr. Andrea Murray from Stanford University, and Dr. Julia Weinkoff from the Minnesota in the United States. Just before we start, we do have a couple of points in terms of meeting etiquette and housekeeping. Our programming is based on a foundation of love and respect. Please respond kindly rather than react if you disagree with something. It is everyone's responsibility to keep this webinar a safe space. We will be using the chat function for Q&A. The button to use that is at the bottom of your screen. Please send all questions through the chat box and feel free to introduce yourself. Please turn on your video if you are able to. Position your webcam effectively to show your face if alone, or to capture the whole group. If you have any technological issues, please send us a message. We would be pleased to support you. And the session is being recorded, and your attendance is consent to be recorded, so thank you. Finally, please be mindful of infection prevention and control. Try to limit the numbers of people joining from one gathering place, and please practice physical distancing. Today, we do have interpretation available in both French and Spanish. To access this, at the bottom of your Zoom screen, there should be a button that says interpretation. You can choose to mute the English part of the session, or you could have both the English and the translation on. The translation will be louder than the speaker in that case. And yeah, so with that, I'll hand it over to Dr. Anna Crawford to start us off. Thank you for being here today.
Good morning, good day, good afternoon. So I'm Anna Crawford. I work within the Division of Global Health Equity at the Department of Anesthesiology at Stanford University in California, USA. I have specialist training in both anesthesia as well as critical care medicine. And I'm also the editor of the Global Anesthesia and Critical Care Learning Resource Center, which is the online platform which hosts all the content that you will see today and that we will discuss. We will also post a video of this webinar on both the Learning Resource Center and the Assist International website. We want to thank our wonderful partners, both Assist International and Project ECHO, and we're also grateful to work in partnership with the World Federation of Societies of Anesthesiologists. I and many of the panelists today are on committees for this international professional organization. We also want to thank the participants who sent in really wonderful questions. We'll talk about most of the questions within the content that we discuss in the case that we discussed today. And if we have extra time at the end, we will attempt to answer the additional questions. But please do join us for upcoming sessions. We plan to discuss basics of intensive care. We also plan to discuss respiratory care for both pediatrics and obstetrics patients in future sessions. We'd like to remind the participants that these discussions and the content on the Learning Resource Center serve to promote the exchange of knowledge and experience of healthcare providers. These discussions are in no way intended to substitute for the clinical judgment and independent decision-making of qualified healthcare professionals. We do make every attempt to provide up-to-date and accurate information. However, information does change rapidly. The creators and authors of the content cannot claim responsibility for inaccurate information that has changed. So individual healthcare providers must be responsible for adapting information to fit the availability of resources within their own institutions and meet those standards of care. A quick note on conflicts of interest and our pledge to learners. The Global Anesthesia and Critical Care Learning Resource Center aims to bring high-yield, evidence-based, peer-reviewed resources to learners, regardless of resource setting. We pledge to keep education open access. We pledge to keep education free from advertising. We also pledge to uphold ethical standards and to approach all learners with compassion. Assist International is an international nonprofit organization, and the Global Anesthesia and Critical Care Learning Resource Center receives no funding or compensation or advertising incentives other than in partnership with our in partnerships. So with that, I'd like to introduce part 5 of this series, the Critical Care Outside the ICU, a Rapid Response. So the practice change objectives today is to define the critical care continuum, to understand the SpO2 or pulse oximetry goals for oxygen therapy, to define and utilize the Q-SOFA, Muse, and Quick CSI scores, to outline the life-threatening signs and symptoms that indicate time-critical care is needed, and to identify the key personnel that offer time-critical care and bring these individuals together quickly. For the learners, one objective is to create or review the rapid response team policy document for your institution, and to practice and simulate scenarios to identify gaps in areas that need improvement. So with that, we will start with our first learning objective, which is defining critical care. I'd like to ask my colleague, Dr. Rodrigo, to start us off with this discussion.
Hi, everyone. I'm Rodrigo Rubio from Mexico. So we are going to start with a poll. So I think you're going to see the poll in the chat. And we have this question for you. Which of the following are considered critical patient care? One would be early recognition. Let me move this to the side because I can read it here. Early recognition, assessment, and decision-making for deteriorating patients. 2, rapid and timely interventions for patients at risk of clinical decline. 3, identification of clinical warning signs prior to cardiac or respiratory arrest. 4, providing expert assistance in response to concerns for patient status. And 5, all of the above. So I'm gonna give like some seconds here for you to respond. So far. Okay. So all of the above is winning. Then we have identification of clinical warning signs prior to cardiac or respiratory arrest. And then we have with 1, rapid and timely interventions for patients at risk of clinical decline, and 1 for early recognition, assessment, and decision-making for deteriorating patients. So I guess it's enough time. Well, more people are answering, so I'll give it a couple of seconds. But I see, you know, so at the end, it was all of the above, and all of the above is correct. You know, when we have a patient, a critical care patient is defined by all these, you know, you have to early recognize, assess, and make decisions for these patients. You should also do interventions rapidly, and rapidly is the main word keyword. You know? Identification warning signs, that's most of today's panel about. Also, it is providing expert assistance in response to concerns for patient status. That's very important, communication, patient and family. And well, since that, it's all of the above. You know? So there's, how can I take this away? There's a statement. I can't read it.
Yeah, so the patients, yes, thank you, Rodrigo. So the Patient Safety Network is an agency for healthcare research and quality. And they state that patients whose, let me clear that, sorry. They state that patients whose conditions deteriorate acutely while hospitalized will often exhibit warning signs. And these warning signs can be abnormal vital signs in the hours before experiencing adverse clinical outcomes. In contrast to standard cardiac arrest or code blue teams, which are summoned only after the cardiopulmonary arrest occurs, rapid response teams are designed to intervene during this critical period, usually on patients on general medical or surgical wards. So oftentimes patients will have abnormal vital signs that we can recognize before they go into arrest. So it's important for rapid response to recognize these signs. Okay, so it looks like, Rodrigo, we have another question.
Yeah, so the second question will be, how would you define critical care? And where does critical care occur? And well, there are three questions. How does critical care differ from intensive care? And we'll have to see them.
So for all of the learners, when you're on the Learning Resource Center, when you see a question box, often you can click on the question box for the answer. So I'm going to go ahead and click on this and see what resource is attached to this question. And so it takes us to an article about the continuum of critical care. And this is by a very famous critical care physician, Jean-Louis Vincent, who talks to us about the continuum of critical care and where that occurs. Rodrigo, what were your takeaways when you read this article? What impressions were you left with?
So the critical care is not a place in the hospital. Critical care is a moment, and there are different moments for this critical care for the patients. There's before the patient arrives at the hospital with people that can be doing CPR or identifying a stroke, calling 911. That's critical care, pre-ICU, and pre-hospital. Then you will get the pre-ICU with all these signs, deteriorating signs that you can have on a patient on the ward, mainly post-surgical or not. And that's very important because if there are some signs that you can identify, and that will, if you identify them properly and on time, then you can call the rapid response team, and patients will get the care and will not go all the way to a cardiac arrest. Then there's the ICU moment of critical care of the patients, and also there's the post-ICU when you discharge a patient to home, where there's also you need to communicate with the people that's going to be there with for the patient, and if they're going to the ward, then some follow-up and communication with the staff there, it's very important. So my takeaway is that critical care is not a place, it's not the ICU, it's a moment where the patient has a resource, a very limited resource, and that's time. Yeah.
I think that's very well put. I like that you identify the limited resources, time. And so I think that was my big takeaway. Also, critical care really means time critical care, and it doesn't necessarily mean ICU. That's great. Anything else you want to say about that article?
No, nothing special.
Yeah, I think you covered the highlights very well. So I want to start us off with the case example. And this is not a real case, but it is definitely pulled from real case examples that we have seen and experienced. So the setting is that you're working in a rural hospital, and the nearest hospital with an ICU is over 90 miles away by ambulance, and the roads are closed because of inclement weather. So I think for a lot of us, we have been in this situation before. The history is this morning on medical rounds, you see a 54-year-old male. He's a patient with a history of coronary artery disease, hypertension, and type 2 diabetes mellitus. He's admitted to the inpatient ward 3 days ago with COVID-19. His chief complaint is shortness of breath. On rounds in the morning, you notice he is slightly tachypnic. His respiratory rate is 27 breaths per minute, but he still speaks in full sentences. He requires oxygen by nasal prongs or nasal cannula, and the oxygen is running at 3 liters per minute. He has a few crackles on his lung exam, but his exam is otherwise unremarkable. Vital signs are obtained. His respiratory rate, as mentioned, is 27 breaths per minute. The temperature is 37.9 degrees Celsius. His heart rate is 95 beats per minute. His blood pressure is 107/59, and his oxygen saturation or pulse oximetry reading is 92%. Dr. Dati, what is your interpretation of the vital signs on this physical exam for this patient?
Thank you very much. Can you hear me?
Yes, good morning, thank you. Or good afternoon, sorry.
All right. From the history and then the findings, this patient has slight tachypnea with hypoxemia, but is afebrile, and the heart rate is normal, but it's on the high side, so high normal heart rate. Blood pressure is normal.
Yeah,
so nothing threatening at the moment, apart from the slight hypoxemia, which we need to watch.
Exactly. I would say exactly the same thing. Let's see, it says that we can click on this question and perhaps get some more resources. So let's do that and see what we have. And it's just a table that reports normal vital signs in adult patients. So that can be a nice resource for those that are new to medicine, or perhaps take care of pediatric patients but are now forced to take care of an adult patient. So, okay. So we'll go on to the next practice. So that first practice objective was defining the critical care continuum. And then the second practice change objective is to understand the SpO2 goals for oxygen therapy. So we have a patient update. Despite 3 liters per minute of oxygen by nasal cannula, 2 hours later, the patient's SpO2 decreases to 86%. When you arrive, he appears to be more tachypnic, breathing more quickly, and is working harder to breathe. He can only speak 2 to 3 words at a time. Dr. Julia, would you mind discussing what the goal SpO2 would be in this adult male patient and what intervention should be taken for this patient?
Sure. Good morning.
Good morning.
Good morning. So do people want to answer? Is this a poll question?
I don't think so. I think
Alana, is this, okay.
Yeah, it's more for discussion.
Okay, so what do people in the audience think? You can put it in the chat box. What's the goal pulse ox saturation in this adult male patient? Anyone want to put something in? What do we think? Is it 100%? Probably not, right? Well, for a long time, we thought the higher the better. You know, people would give, okay, we have a 94%. 92%, 95 to 98. Okay, so for a long time, we sort of thought the higher the better, and most people who were critically ill, we would just give them oxygen until they were 98, 99, 100%. But then people started to question whether that was really appropriate. And some studies were done that took two groups and put one group of patients on oxygen, say greater than 96%, and another group of patients on oxygen for a saturation less than 96%. So for this patient, we definitely want him to be more than 86%. What would you do to get his oxygen level up? What sort of oxygen delivery device do you think would be appropriate? There's many things you can use. Usually we would just start with a nasal cannula or a mask. This person has probably mild hypoxemia, so you probably don't need to go to something like BiPAP or CPAP very quickly. Anna, do you want to show the graphics for the different?
Well, I have two things. I have two things, Julia. I have an article that discusses oxygen goals, and it makes a couple recommendations that were changes from previous goals of care. And if you want, I can find the graphic that shows the escalation of oxygen therapy devices. Which were you thinking?
Oh, the one that you have up right now is where I was thinking we would go next, but.
Yeah, wonderful.
So people are saying nasal prong or face mask in the chat, and that's good. And here's some pictures, some graphics that show some of the evidence behind what we want our target pulse oximetry reading to be, our target oxygenation saturation. And the graphics are a little bit busy, but we'll walk through it here sort of slowly. So at the top, you can see the overview of recommendations. And these recommendations come largely from a meta-analysis where some folks looked at a whole bunch of different studies. It was, I think, 25 studies, and they looked at all the different patients that had been randomized to a group that got more oxygen and a group that got less oxygen. And then they looked at what happened to those two groups of patients to help us decide how much oxygen we should put them on and what their target oxygen level should be. So the number one recommendation you can see on the top there that has strong evidence is that a target oxygen level does not need to be more than 96%. Once your patient is up to 96%, you can shut that oxygen level off. The second recommendation, which isn't quite so strong, but still recommended with weaker evidence, is that probably it's okay to have your patient just have oxygen saturations greater than 90%, 90 to 92%. That's not quite as strong of evidence, but still probably safe and recommended. The third recommendation, which is a strong recommendation, is that your patients don't need to have oxygen levels greater than 93%. That seems pretty assured. And if we go down, we can see some more details on each of these recommendations. So recommendation number one, you'll remember, was a strong recommendation. And these are for critical patients who all critical patients, with the rare exception of a few diagnoses like carbon monoxide poisoning or sickle cell crisis or collapsed lung, some other serious lung pathology. So most of our patients meet these criteria. And these patients were randomized to have oxygen levels greater than 97% or less than 96%. And it was found that the patients who had less than 96% oxygen levels did just fine. And in fact, they did better than the patients who had more than 96%.
So Julia,
yeah.
I actually had, before the session, someone email me and ask me why cluster headaches was included in this group. And I have to admit, I didn't actually know the answer offhand, but I looked it up, and patients that are diagnosed with cluster headaches, one of the treatments is to give them 100% oxygen. So that's why they excluded those people from this group.
Okay.
Interesting little fact about cluster headaches. Yeah.
Yeah. So here's a little more detail on our second recommendation, which was investigating whether it's safe to let people just have an oxygen level greater than 90%. And it's not as strongly recommended, but it is probably safe, and it is recommended that 90 to 92% can be your low level of oxygen saturation that's safe. So you can go ahead and do that with fair confidence. And then down a little bit more to the third recommendation, this was strong evidence. It showed pretty clearly that these two groups, when they were randomized, did just fine with oxygen levels greater than 93%. So that's a very, very clear recommendation that it's safe for your patients to just have 93% saturation. Any questions about this in the chat? The complications that they looked at in all of these studies included hospital length of stay, hospital mortality, and complications, specifically infections, so pneumonia and other infections. And in most of the studies, mortality was actually improved, and the infection rates were improved in some of the other ones. So those were the major things they were looking at to see whether it was safe. And it's good to know that this applies even in patients who have heart attack or stroke. Even after we started to feel confident that it was safe to let people have oxygen levels in the low 90s, for a long, long time, people still held out with those patient populations. They wanted to say, well, that's fine for all these other ICU patients, but in heart attacks and strokes, we still need to have people have very high oxygen levels. But these studies show that that's not the case, that these lower oxygen levels are safe and actually better than those high oxygen levels. So now we feel pretty confident about that as well.
That's great, Julia. Thank you so much. I think that's a really important thing. And I think we can see from the chat all the different answers and goal SpO2s that people have listed, and they're all very different. So it tells us that there's not great understanding or consensus on the goal SpO2 for these patients. So I think it's good to use an evidence-based approach and guide our clinical care to recognize that really we shouldn't start oxygen until the SpO2 is less than 92%. And we shouldn't aim for 100% FiO2, that really getting up to 96 is probably fine for most patients. So thank you so much for that, that great discussion. So we have another clinical update on this patient. We got a new set of vital signs, and we now have a respiratory rate of 32. We have a temperature of 39 degrees Celsius, and his heart rate is now up to 115 beats per minute. And unfortunately, the non-invasive blood pressure cuff is showing that the blood pressure is down to 83/55. And now the SpO2 is 86, which is abnormal according to all of the scales that Dr. Julia just discussed. So unfortunately, our clinical course is worsening. So our next practice change objective is to use clinical scores to help us determine what care is appropriate for these patients. And so I'm going to ask my colleague, Dr. Nicholas, to define and use the QSOFA, the MUSE, and the Quick CSI score. Dr. Nicholas, have you used these scoring systems? And if so, can you tell us your opinions and how you use these scores clinically?
Yes, good morning, Anna. Thank you, and good morning to everybody. Yes, I usually use these scores every day, especially to identify all these patients that will probably need to be admitted to the ICU, and also to identify them probably in a regular ward and see how maybe they are deteriorating or getting worse, or so we can quickly localize them and treat them and use all the resources we have to give them the best treatment. And I think these are really easy scores to apply, and which they can give us like really important information about the patient status.
So I think this next question might be a poll question. If we could get our Project Echo team to launch the poll. There it is. Thank you. So we'll have the audience answer this one for us, Nicholas.
Okay, so the question is about the case we were talking earlier. Which of the following are possible differential diagnoses for the signs symptoms? First, we have sepsis. Second, we have SIRS. Third, we have respiratory failure. Four, we have ARDS, and all of the above.
And this is for our patient. So we'll go back and here are the vital signs for this patient. So it might help you decide which of these differential diagnoses might apply to this patient. SIRS is systemic inflammatory response syndrome. So SIRS is systemic inflammatory response syndrome, and ARDS is acute respiratory distress syndrome. ARDS. That's important because in our different languages, in our English, our French, and our Spanish, we use different letters and different descriptions, but they have a common definition usually. So Nicholas, it looks like most people are answering all of the above. What do you think?
Yes, I think that it is a very good answer and correct answer because it's really, sometimes it's really hard to differentiate this type of all of these diagnoses. So we can use this course exactly to know what's happening to the patient and which patient will be needed an admission to the ICU probably.
So what is the Q SOFA and when should it be used?
Okay, can we open the
Of course, yes. So
again,
audience, if you click the question, oftentimes you will get a nice resource that you can use to find the answer. So this is a website that's called MD Calc. It has many different scoring systems, calculations, etc. So this is the one for the quick SOFA.
Exactly. So as we can see, the quick SOFA is its score for sepsis, and it helps us identify high-risk patients for in-hospital mortality with suspected infection. And this is very important outside the ICU. Okay. So why are we going to use it? So because it will help us identify patients outside the ICU with suspected infection that are at a high risk for in-hospital mortality. And it can help increase suspicion or awareness of a severe infectious process and prompt further testing or closer monitoring. And it's really important that it is used to predict mortality and it is not a score to diagnose sepsis, okay? And this is all based in the 2017 Surviving Sepsis Guidelines. So as we can see, it's a really easy score to use. It has 3 parameters. One of them is having an altered mental status, which we can assess by using the Glasgow Coma Scale score, yes. And it must have a score lower than 15. Also, another parameter will be respiratory rate, which must be equal or above of 22 respirations per minute, and a systolic blood pressure lower than 100. Okay, so if we have the cutoff point is 2, so with 2, we can identify patients who will have a higher in-hospital mortality and probably due to an infectious complication. So as we can see, it's really easy to apply. We can do it at the bedside of the patient, and we can quickly identify all of these patients who are arriving to our hospital or to our emergency department, and then know which one of them who might have a worse outcome.
So Dr. Nicholas, do you mind if I do this for the patient in the case? So our patient does not have, it doesn't say that he has altered mental status, but he does have a very fast respiratory rate. And he also has a systolic blood pressure that is less than 100, doesn't he?
Yes.
Okay. And so This COVID question is actually just for research. It's not part of the quick SOFA score, just so the audience knows that. But when we put in those two parameters, you said the cutoff is 2. So what would you consider this patient?
So as we can see in the result, it's a high-risk patient. So it has 3 to 14-fold increase in hospital mortality in compared to patients who doesn't have this score. So the important thing is that we have to assess for evidence of organ dysfunction in these high-risk patients with blood testing, including serum lactate and calculation of the full SOFA score. And
Great.
Patients meeting with these Q-SOFA criteria should have infection considered, even if it was previously not considered.
Wonderful. Thank you so
Yes.
much for that explanation and use of the quick SOFA score. Okay, I have another question for you, Dr. Nicholas. What is Muse and when should it be used? So I'm going to click on the question for us so we can find the resource. Okay, thank you. You're doing such a great job.
Oh, thank you.
Okay, so what does Muse stand for?
Okay,
It takes us back to the same mdcalc.com website that we're going to use again.
Yeah, great. I use MDCalc all the time. So as we can see, Muse, it's a modified early warning score for clinical deterioration, and it helps us determine the degree of illness of a patient. Okay, so why are we going to use it? Okay, first of all, because patients with low Muse can continue receiving their usual care and observation. Maybe this can be in a regular ward, maybe this can be in the emergency department or in another department of the hospital. And patients with high Muse should be watched more attentively and considered for transfer to a higher care unit, such as the ICU. So as we can see, all of these scores help us identify quickly and earlier patients who will probably need ICU and patients who are in a high risk mortality during their hospital admittance. So as we can see, this score has 5 parameters. One of them is the systolic BP. As we can see, as lower the BP is, higher the score is. So remember, higher Muse are related to more probability to be admitted to an ICU or more care. As we can see, there's another parameter like heart rate. So
I'm going to go ahead and fill in the values for our patient as we go along. Is that okay with you?
Yes, perfect.
If I remember correctly, the systolic blood pressure
was 88, maybe?
Was 83. The heart rate was 115. Okay. Temperature, fever, respiratory rate 32, SpO2 86. Okay, so let's go back and fill this in. So 83. Exactly. We said 115 on the heart rate. Yes. And the respiratory rate was over 30, wasn't it?
It was over 30, yes. Temperature was 39.
Okay, temperature was 39. Okay, and we still don't have information about the
consciousness level
mental status, but we said he was talking in full sentences or 2 to 3 word sentences, so we can say he's alert.
Yes.
Okay, again, COVID is for research, and so I'll let you discuss this.
Yeah, so our patient has got 8 points in this score, so it will give him a 30% chance of ICU admission or death within the 60 days. So we have to consider a high level of care. So we can identify this patient and promptly admit him to the ICU. Okay, so it's also good to know that for any single physiological parameter with a sign score of 3, we have to consider a higher level of care for patient.
I just want to point out to the participants that this resource has the evidence. So it has the studies that were used to come up with these scoring systems. Can I ask you one question, Dr. Nicholas? If you were in a rural hospital and perhaps your facility did not have an intensive care unit, would you use the Muse score to determine if this patient should transfer to another hospital that has a higher level of care?
Yes, probably I will not use it as a single tool, but I will take it into consideration with another scores, like for example, the Q-SOFA, or maybe calculating the complete SOFA score. And of course, I will be monitoring continuously this patient and will move him out of the hospital as soon as I have gathered all the information. that will tell me that he's in a high risk of developing maybe organ dysfunction, and with that, an ICU admission.
Wonderful. I'm asking a lot of you, Dr. Nicholas. Do you have one more question in you? If you don't mind, what is this QCSI score and when should we use it?
Of course. We can go to MD Calc again.
Oh, we love this website, don't we?
Yeah.
Okay, when to use the quick COVID-19?
Yes,
COVID-19.
as we can see, it stands for quick COVID-19 severity index, and it predicts 24-hour risk of critical respiratory illness in patients admitted from the emergency department with COVID-19. Okay, so we have to consider applying this score to risk stratified COVID-19 patients who are being admitted to the hospital. The derivations, well, so we have three main parameters. So as we can see, they are easy and we can do it in the bedside of the patient. The first of them is the respiratory rate. As we can see, the higher punctuation we have it when it's above 28. The pulse oximetry, it will be the highest score when it's lower than 88. And the O2 flow rate, which will be with the higher punctuation when we are using 5 to 6 liters per minute. So this is the score of our patient, right? He had 30 RPM. He had a pulse oximetry of 87, I think.
86.
And
yeah.
86, okay. And a flow rate of 7, I think, or 6 or 7 liters per minute. So as we can see, we have a 12 points in the QCSI score. It gives us a high risk group for a patient, and we have a 57% risk of critical illness at 24 hours. So we will have to pay literally like a lot of attention to this patient because it has a high risk of deterioration and probably of admitting to the ICU, mechanical ventilations, and all the complications we know about these COVID patients.
Dr. Nicholas, we're very grateful for you sharing your expertise. Thank you so much for joining us, explaining these very useful clinical scoring systems so we know when to escalate the care of our patients. So thank you so much.
Thanks you.
So we're going to move on to our next practice change objective, which says that we should outline the life-threatening signs and symptoms that indicate that patients need time-critical care. And so I'm going to ask a couple of our other colleagues to go through this. But first, it looks like we have another clinical update on our patient. It says our patient suddenly loses consciousness. So we get new vital signs that are obtained. And our vital signs include a respiratory rate of 40, a temperature of 39, a heart rate of 147, and a blood pressure of 63/25. And now the oxygen saturation is 66%. So I'm going to ask Dr. Freddy, if you don't mind, which of these vital signs or clinical exam findings require immediate intervention? What are your thoughts, Dr. Freddy?
Oh, thank you, Anna. Good morning and good afternoon for everybody. In this patient, the respiratory rate is a highlight sign that remains that have to be urgently approached. This patient is going to be worsening. We have seen how this patient is worsening with age of the assessments. So it's probable that this patient requires a high level of care. So it's probable that the response maybe need to be quickly, and he needs a very specialized team for the care. So undoubtedly, this patient is worsening and requires a high critical care immediately. Because
can I ask Eli, Dr. Freddie, Eli is actually on our critical response team, and also Sean, if you don't mind. These two gentlemen are part of our critical response team at Stanford University. So I think you would want to call them to help you, Dr. Freddie, respond to this emergency. So I'm wondering if Eli and Sean can comment on these vital signs and just determine if they would respond to these vital signs or consider them.
Oh, please help me, Eli and Kiara, help me.
Perfect.
I would say kind of looking at these vitals, the direction that the patient's heading is almost to be a code blue event because they're unconscious. Their blood pressure is 63/25, they're statting 66%. So at this point, we need to stabilize the airway. We have to also control their blood pressure and to stabilize them enough to be able to transport them to a higher level care. Typically in this event, if this were happening at the bedside, the nurse would most likely be calling something what we call as a code blue, which would get multiple resources, including our team, as well as our MICU doctor, which is the medical ICU fellow, as well as anesthesia team who can intubate, as well as respiratory therapy. Some of the key points of like just how our response team works is the goal is to facilitate early intervention and stabilization of the patient who acutely deteriorates outside the ICU prior to cardiopulmonary arrest or other potential life-threatening events. And what was mentioned earlier is that like critical care is a moment in time, and this team is able to facilitate essentially critical care on a one-on-one basis until we can transfer that patient to a higher level care. It's not like that patient, he or she, needs to be in the ICU to get that. We bring the critical care to the bedside, and the hope is that we can prevent a cardiac arrest or prevent worsening outcomes for that patient and to safely transfer them to that higher level of care that they need.
So there's two statements that have been stated today already this morning that really resonate with the core theme of this discussion. And it's that time critical care is time critical care. And Sean, I like the way you said that we bring critical care to the bedside. And I think that's a great thing. And so you mentioned in your hospital at Stanford University that there's a team of people that respond and that the nurse can call for this team, and there's very specific people that respond. So I'm going to click on this question and see what resource comes up. And it looks like we have another learning module on the Learning Resource Center that outlines the triggers that can possibly be used to call this specialized team of providers to the bedside. And so rapid response teams and code blues. And so this is just a chart that outlines some of the common reasons that bedside nurses or bedside providers or even bedside family members can use to call and activate a rapid response system. So we have a patient that has an abnormal heart rate, abnormal respiratory rate, abnormal blood pressure, abnormal oxygen saturation, but also an acute change in mental status. Also, patients who are potentially going into renal failure, that might be a reason to call for additional help. If any staff member has a significant concern about the patient, then we can call the rapid response team. Chest pain that's unrelieved or pain that is unrelieved, a patient with an unstable airway or seizures that are not controlled. These are other common reasons to trigger a rapid response system or a rapid response team. So the question then becomes, what is a rapid response team and a rapid response system? What does that entail? And so we have two resources here. One is a way to establish rapid response systems and teams. Whoever that is mute in the background. Thank you, appreciate it. And then the second resource here is called an emergency manual, and it's actually a really good thing that you can download and print for your hospital. And it has different scenarios that occur in real life, and it has very concise instructions for how to manage each of those scenarios, including things like unstable airways or ACLS algorithms. And then we also just have provided some interim guidance for CPR during COVID-19. So we'll go back to this rapid response reference here. And if you click on that, it will take you to a website that has all of the steps. It's actually called Team Steps to set up rapid response systems. And it's a module that goes through definitely a lot of steps, but it discusses each step along the way to create and implement rapid response systems and teams within your institution. Additionally, it has several scenarios that you can use to practice once your rapid response system is set up within your hospital. This is a very long module of training, and so we won't go through it in full detail today, but this website can be posted in the chat box so that you can pull it up yourself within your institution and adapt it to the resources available to you. So Dr. Freddie, I have another poll question, if you don't mind. Can you read this next poll question for us?
Thank you, Dr. Anna. Okay, guys, which of the following interventions may be needed for this patient? You know this patient is worsening, and there are many options. Which of the following interventions may be needed for this patient? Okay, while the colleagues answer the question, I have to say that in 2003, the National Quality Forum identified the ERS as a chief example of team intervention, serving the safe practice element of team training and team interventions. ERS are viewed as an ideal example of safe practices in teamwork, meeting the objective of establishing a proactive system approaching to team-based care. Okay, enough time to the answering. So Eli and Chiara, may you share us your experience with this ERS? And this is the answering, all of the above, effectively. This option covers all the situation of intervention needed in this patient. Eli and Chiara, have you shared your experience with us?
So I don't know that Chiara was able to join us today, but I'm wondering if Eli, if you don't mind sharing your experience, yeah, with rapid response teams, and if you would like to add anything to the discussion about how to implement them and what the goal is of a rapid response team, in your opinion.
Yeah, I love the definition of critical care being just that moment in time. But I think, yeah, rapid response is really bringing critical care to the bedside and preventing worsening of the patient. So whether that means stabilizing the patient on the floor or the ward, or transferring the patient to the ICU, or running a code blue, all of the above is kind of our intervention. I think Stanford is one of those examples where we have a lot of resources, and our rapid response team comes with 4 response nurses, sometimes 5, respiratory therapist, pharmacist, ICU fellow. So we just have a lot of resources. But I've also worked at a rural hospital where you don't have those resources, where really it was actually just the ICU fellow and the ICU charge nurse who came to the rapid response. So I think at the bare minimum, that's an example of a team where you have an ICU in the hospital, and they may be busy taking care of many patients, but they have an ICU doctor and a nurse who can show up to the bedside when the patient is deteriorating, and they can again bring that critical care to the bedside as well. So I think there's just very different examples of a rapid response team, and it doesn't have to look in one way.
Thanks,
Eli,
Dr. Eli.
I have two questions for Eli, if I may. Eli, when you say you've worked in a rural setting and often the rapid response team might just be the ICU doctor and a nurse, what would you think if there were no ICU? Who would respond? Who do you think would be a next most appropriate person or persons to respond to a rapid response?
Yeah, if there's no ICU, I think it would be the emergency room doctor and the emergency room nurse in those cases.
Okay. And because they probably have the skill set that's most aligned with airway management and management of quickly changing hemodynamics. And what do you think about anesthesiologists? You're in the company of lots of anesthesia providers here, Eli. Do you think they have a skill set that might be useful for those?
Oh yeah, absolutely. Yeah, I think in some hospitals, CRNAs respond to the codes and they often run the code as well. So any anesthesiology or CRNA should be capable of running, managing an airway and then managing vasopressors. So I think those are the key things that the floor is not comfortable with.
Okay, I'm going to clarify two things that may not be available to everyone. First is a respiratory therapist. Not everyone on the globe has access to respiratory therapists. And oftentimes we don't actually call them respiratory therapists, even if they're there. They're sometimes called physio, right? So a respiratory therapist is a specially trained provider that manages things like oxygen delivery devices, mechanical ventilators, et cetera. So not all countries actually have respiratory therapists. That's something that we have in the United States, but not everyone does. And then the second, Eli, as you mentioned a CRNA. What is a CRNA?
Certified Registered Nurse Anesthetist.
That's right. Yeah. And so not everybody has nurse anesthetists either, although there are lots of countries that do have anesthesia providers that are not physicians. And so those providers would be equivalent to that skill set where they could manage an airway. So those providers are also very useful in these settings. Okay. Dr.
Okay,
Freddie.
Anna. Okay. Another question from space. Okay. Does your facility have a rapid response system for inpatient? Please answer the question with yes or not. Does your facility have a rapid response system for inpatients? Please respond for the pool 2 or write your answer. Okay, I see many yes. And many no's too.
And many no's, yeah.
Yeah. Okay, time is over.
We have one person who responded, I don't know. So that's interesting too.
Wow.
Yes, no.
Wow, interesting. Yeah. Oh.
Yes, no, and I don't know.
Same proportion.
It's almost 50-50, yeah. Very interesting.
Yeah, okay.
So since
this is an important question. This is an important issue because many of the caregivers don't know who are a rapid response team. So, Eli, who can activate a rapid response team for what triggers?
Yeah, so I think one thing I'd like to mention for this part is that we encourage all the staff to be able to call rapid response anytime they feel uncomfortable. And at times that might be a false alarm. Maybe the patient ended up being okay and it was just a false monitor alarm. But we really want to encourage nurses and the staff to feel comfortable calling it because it's a safety issue, right? So some hospitals can be very harsh in terms of discouraging nurses calling rapid response if it was a mistake. And I've seen doctors get really angry, but we really as a team at Stanford try to encourage nurses and staff that anytime you feel like a patient is not doing well and they are deteriorating, just call a rapid response. And the worst thing that will happen is we show up, oh, actually patient's fine. But that's better for the patient, it's safer. And that's something that we really try to encourage, that culture of safety.
Yeah, and I would like to add that the response team also provides education and training to the nursing staff, and that we try to really empower the bedside nurse to be our eyes and to be that early warning system to recognize kind of deterioration and to give us an early heads up. And what Eli said, like, we are totally comfortable coming, and if it's a false alarm, that's great. You know, it's the best thing for the patient. Yeah.
So I would just like to point out on this current resource, this is a table that you can click on the Learning Resource Center and get to this article. But it's a table that lists the triggers for rapid response team activation. And it not only lists the vital signs or clinical signs that can be a trigger, but also who can call for the additional resources. And it can be a nurse, it can be a physician, it can be physiotherapists, and it can also be non-medical staff. And so this is sometimes a bit of a debate, but even patients and or patient family members can also call for additional help for their family members. So this lists a lot of signs and symptoms that can be used for nurses to know if the blood pressure is too low or the heart rate is too fast or the oxygen is too low, or even if the patient loses consciousness, et cetera, why they called the rapid response. And you can see the rates at which those were called. And then it also has the final diagnosis that led to the RRT. So these are the common reasons why the rapid response team was activated and what was going on with the patient. And I think that's important information to determine what resources, since we're bringing critical care to the bedside, what resources we need to bring with us. So it's not just providers. So I'll ask Sean and Eli to comment once again. You mentioned the providers that come to the bedside, but what else do you bring with you when you respond to the rapid response call?
Recently we've been also with the COVID pandemic, we've been bringing COVID supplies because in times of crisis, you know, we had to have additional equipment with this pandemic. But
are you
typically,
talking about PPE? Do you mean
PPE? Yeah, COVID. Yeah, typically, if it depends on the call. We have two different types of notification systems. We have a code blue call, which is usually the patient is either pulseless or needs emergent intubation, or we have something called a rapid response. Typically with a rapid response, it is patient still has a pulse, is usually still awake, but they could have a very low blood pressure and needs emergent attention. So typically with those, we respond with our several response team nurses, and usually a resident will come to the bedside. We then will assess the situation at the bedside and determine what our course of action needs to be, if more supplies need to be gathered, if we need our team to help facilitate a transfer, as well as looking to the recommendations of the MICU fellow to determine our course of plan. Every situation is different. Yeah.
Yeah. Eli, did you have something?
Yeah, I would say we have most of what we need in the crash cart and in the units as well. But what's the most important part is the pharmacist shows up with their bag of medications, and they have everything, all the pressors, all the intubation meds. That's really, really crucial for us.
I would at this time maybe ask some of our other panelists just to see if they have anything to add to that. We're about to actually go into our third our next practice change objective, which is to identify the key personnel that offer this time critical care. But I'm going to ask Dr. Julia, Dr. Dati, Dr. Andrea. I don't know if Dr. RJ is with us. Are there other things that you would like to add to this discussion about rapid response teams?
Yes, Anna.
Yes, Dr. Dati, thank you.
Yes, a very interesting discussion. Now, if you look at the poll, whether we have rapid response team, that's why you see the yes and no is almost a tie.
Yes.
Actually, they do exist, but in our practice, for many years, many people don't know. Well, the practice is that in the typical general ward, medical ward, the nurse is asked to monitor these vital signs 8 hourly. That's the minimum. And you can see with that case, the case discussed, in 2 hours, there's a deterioration. So they won't be able to know. So what they need to know is to be, right now, the rapid response team in my hospital, they are the anesthesiologists. Most of our colleagues, they don't know the early warning signs or the modified early warning signs. And now with the COVID-19, there is more people now are educated. They are now aware there is a pulse oximeter, which can make a difference in monitoring. And then actually each ward should have an area where a patient whose vital signs is unstable, you have somebody get tachypnea, and then there is a desaturation, then that patient should be monitored closely. Now, what is absent is this team and to know all their routes. So the first thing that can be done first of all, the rapid response team can make a great difference in low resource settings. When you empower the nurses with pulse oximeter or multi-parameter monitor where possible, it eases their work, and then you will see a trend. And then when you have a team, then you teach them. There should be constant training with simulation like this, and then they will be able to key in. It will be difficult now with this COVID-19 pandemic. Constantly, we are getting to know more and more, and then we can do with very little. We can do more with very little at the moment.
Dr. Dati, these are excellent points, and I think it's very, very important to point out that that you can do a lot with low resources, and that rapid response systems look different in every single institution, whether it's a high resource setting or a lower resource setting, that these rapid response systems really are tailored to the resources available to you. I think it's remarkable that 50% of our audience does not have a rapid response system in place. And so the importance of this session, I think, is stressed through that percentage or that poll. I think every place can set up a rapid response system regardless of resources. And I think, Dr. Dati, you make excellent points that even if it's just to put the pulse oximeter in the hands of a nurse who goes and checks on a patient that another nurse calls and says they're concerned about, and changing the frequency of how often vital signs are checked, I think is a critical care intervention. That in and of itself, checking vital signs more frequently, is part of this continuum of critical care. I think your points are very well made and very, very important. So thank you so much for sharing that, Dr. Dati. Do any of our other panelists have additional comments about rapid response systems in general before we get into the personnel that might be part of this team?
Yeah, this is Julia. I think one of the things I was thinking as the folks were talking about rapid response teams is that it can be very confusing as a patient gets sicker, who to call for what, because so many things are going wrong. There's so many different vital signs that are abnormal, and there's so many different potential people to call. And so that's a major advantage of the rapid response team, is that it does give clear responsibilities to certain people to take out some of that chaos and confusion.
I think that's an excellent point as well, Julia. And I think the benefit of identifying the people who respond to that call is, as you describe, identifying the role of perhaps a senior physician. It may not be an ICU physician, it might be emergency medicine, anesthesia, internal medicine, whoever, but it will assign a role to a senior physician to make decisions for that patient on how best to escalate care if needed. I think another subtle point that you're making, Julia, which is also very excellent, is the difference sometimes between a rapid response team and, for example, a code blue call. Sometimes that distinction is not very clear. So, so even just calling the rapid response will activate a lot of the same resources that might be called for a code blue, so that those critical care resources are brought to the bedside. And so the difference really is, in my mind, ACLS or for a patient that has coded or who has arrested versus a patient who's just unstable, that we might be able to deploy some interventions that can prevent that patient from becoming a code blue or from having an arrest. So
exactly, yeah, exactly. And there's that was exactly how the gap was identified that led to the creation of rapid response teams. Is it was noticed that many patients would have a Dr. Blue or a code blue called on them when there had been early warning signs that were missed of that arrest that was impending. And so they created rapid response teams as an early intervention to try and prevent those from ever happening. And there's a lot of really good evidence that that is the case and that it does work.
Wonderful. Thank you so much for those points. Those are all excellent. So let's, if you don't mind, if there's no more comments, we'll move on to the practice change objective that states, identify the key personnel that offer time critical care. So in the chat box, maybe the audience can type, who do you think should come to the rapid response team? Who do you think should respond when a nurse is called? Or when a nurse calls a rapid response? I know that Eli mentioned the importance of the pharmacist, which is a great point. So the participants or learners or audience, who else should come? If somebody is unstable. A physician, good. Susanna says a physician should come, maybe even a senior physician who can make decisions about the next steps in care. Who else should come? Respiratory person or airway, great. So that airway person might be a nurse anesthetist, it might be a physician anesthetist, it might be an emergency medicine physician who's trained in airway, a nurse leader, great. Thank you, Christian. Mustafa says anesthesia. Richard says anesthesia. Because many of the panelists are anesthesia, we're also going to say anesthesia. We think that we have a good skill set that we can offer to patients who are unstable. Pharmacist or someone with instant access to medications. If available, an ICU specialist. Thank you, Maria. Teams of ICU, Jean-Baptiste. Wonderful. So these are all excellent answers. And again, it depends on the resources that are available in your facility. But I would encourage you, for the 50% of people who don't have a rapid response team at their institution, to maybe consider forming a committee that will help identify the resources that are available at your institution and coming up with a team that would be able to not only respond, but bring all the appropriate equipment and medications. So in addition to medications, what equipment would we want to bring to this rapid response from our panelists? Papicho is here. Hello, Papicho. He says, any trained staff, because not all institutions have subspecialties. That's absolutely correct. Good morning, Papicho, or afternoon. So from the panelists, what equipment would you bring to a rapid response team? Maybe Sean and Eli can answer, or Dr. Julia, Dr. Dati, Dr. Freddie, Dr. Rodrigo, Dr. Andrea, Dr. Nicholas. What equipment is often brought to these emergent situations or critical situations? Oh, Dr. Vanessa's here too. Hello, Vanessa. What would you bring to a rapid response team? If you can unmute.
Yes, if I can unmute myself.
Nice
Hi, everybody.
to see you, Dr. Vanessa from Switzerland. Thank you for joining.
Sorry, I was late. I was on duty in the COVID ICU today, so I was a little delayed getting out.
No problem.
So
no problem.
I would bring my favorite pharmacist, a code card, and emergency drugs, emergency airway equipment, and a pulse ox, some monitors, so I can get some basic vital signs like a blood pressure, a pulse ox, depending on what is going on, so that I can get a first impression and then go from there. So drugs, monitors, oxygen, airway equipment.
Wonderful. And what about an IV? Would you like IV access?
Oh, yes. If there is no IV, that's great.
I had a feeling you might want some IVs because you might want to give your medications through the IV, right?
Yes, that's fantastic. Yeah, good addition there. Yeah, if there's no IV, I would definitely have somebody place an IV. What is very helpful in code situations when people don't have good veins or access is very difficult to have an intraosseous needle available. And that's usually a very easy thing to do, to put the IO needle into the humerus or tibia in a matter of seconds to get very rapid access.
Yeah, that's great. That's your emergency medicine training background coming out. I can hear it. So one thing you mentioned, which may not be available to all of our learners and participants, is you mentioned a code cart. So I'm wondering if our panelists can share with the audience what a code cart is and what you would put on a code cart and what this means. So Dr. Julia, do you have an answer for code cart? What is in your code cart?
Sure. So the code cart is all of the most likely utilized pieces of equipment that fall in any of those categories that everyone just mentioned. So it's not everything that you might need, but it's kind of the most likely things that you might need. So there's some airway equipment in a code cart. There's some IV start equipment usually in a code cart. There's some, oftentimes some gowns and gloves and some sterile personal protective equipment for doing procedures, and then the equipment to do those procedures. So arterial lines, central lines, things of those sort. Sometimes in some places, code carts also have some of the medications. They almost always have the emergency medications. So epinephrine, atropine, bicarb, calcium. In some places, they will also have some of the things you might use like vasopressors, sedatives, paralytics, but that depends a lot on how controlled those substances are. So it varies a lot from country to country. Oxygen delivery devices, things of that sort.
Dr. Nicholas and Rodrigo, do you use cognitive aids, and are those on your code cart? Can you tell us about cognitive aids?
Yes, I was about to talk about that.
Good. I read your mind. I read your mind.
We have the Stanford ones in some of our crash carts, mainly the ones that are at the OR. We have them in Spanish, so it's accessible for everyone. And then in the code cards that are on the wards, they have the ACLS basically. But we are trying to move in the hospital everything to have more than ACLS cognitive aids. So, but yes, and constantly in simulation, we try to remember everyone that they don't need to remember everything. The patient is not an exam. You need to remember things when you are in an exam, but when you're treating a patient, you're not in an exam, and the patient does not have the fault of your lack of memory in that moment. So using cognitive aids is it's a great way to ensure the best treatment for the patient. So yes.
So I'm going to go back to a resource that we shared earlier when we saw the rapid response teams and we talked about team steps. And then I mentioned the Stanford Anesthesia Cognitive Aid Group Emergency Manual. And I think it's interesting. This manual has spread across the globe, and now even Rodrigo, you're using it in Mexico, which I think is fantastic. So I'm just going to click on this resource for the audience and realize that this manual is free online. You can download it in English. You can also download it in many foreign languages. So there's a Chinese, Dutch, Francais, German, Korean, Portuguese, Espanol. So you can download this version, and they update the versions often. And what happens is, this is in Spanish, but you can see that you have very common ACLS algorithms. You have hypotension, you have anaphylaxis, you have bradycardia, bronchospasm, pulmonary and amniotic emboli. So lots of very common medical emergencies. And if you go through this manual, again, in many different languages, you can download this manual, you can print it, and it has very easy to read, very quick recommendations for each one of these critical scenarios. So this is a very valuable resource that is available to all of us across the globe in your language. So you can use this cognitive aid for that. So great. So that was up here under this question here. If you click on there, it's also located in several other places on the Learning Resource Center. And then if we can share that link, which it's already been done in the chat box, you can click that link and find that emergency manual. Wonderful. We're getting close to running out of time, so I'm going to move on. We talked about who are the stakeholders needed to implement a rapid response team. And I think for that, we mentioned the patient, the nurses, the bedside providers. We mentioned the physicians who respond, the nurses who respond, the pharmacists who respond. But there's one other stakeholder that we haven't mentioned that I really want to encourage you to think about, and that is the hospital leadership and administration of the hospital. It's really important to get them to buy in to the idea of developing rapid response teams and rapid response systems, and to facilitate their success. So when you do form your rapid response system committee, if you don't have a team yet, make sure you include hospital leadership, and they can really be helpful in making sure that your team has success. And this is a patient safety issue, so they should be motivated to support you. So what documentation should occur during a rapid response team? I'm going to let Eli and Sean answer this, but I do have an example here on the Learning Resource Center that you can use. And I'll just point out quickly for all of the audience, if you notice on the Learning Resource Center, anytime you see this paper clip up here in the right-hand corner, if you click on that paper clip, that means there are resources that are available to you for download. So there are lots of articles up here. The slides from this presentation are here, the Critical Care Continuum article, and then also this example of a rapid response team. So if you go to the Learning Resource Center and click on that paper clip, there's all these resources should be already uploaded, and you can pull them down for use at your facility. So back to you, Sean and Eli, if you don't mind, if you have time, tell us what are important documentation parameters for the rapid response team.
Yeah, I think this is a great example of our RT sheet. We tried to simplify ours recently as much as possible. And one of the reasons is because in an emergency, nurses are very nervous, as we all are. And trying to chart a very complicated sheet is difficult for the bedside nurses. And often the rapid response nurses and doctors are busy performing interventions. So we try to simplify it to really just the time and the interventions. So medications, interventions, when CPR was started, what med was given, what drip was started. So that's kind of what we really simplify it to. And then the nurses can always back chart all the other important part, like who was there, who were some of the doctors there, what was the reason we called the RRT. But we really try to simplify it to time intervention for the beginning during the RRT.
Sean, do you have anything to add about documentation or what your opinions are on what should and should not be included?
I would say, like, you know, what Eli was saying, it's kind of like what is happening there and then, as far as just getting your vitals in, what interventions were given, and this is including like things such as, did you intubate the patient, what medicines were given, what procedures did you have to do, was an A line started, just kind of like what are the events happening right there then during the code blue or during the rapid response. And what Eli said later, it's like, well, the other things can come at a later point in time when the patient's stable or we've transferred them, then we can add our what we call the code blue event or the rapid response event, where we document all kind of what happened prior to the patient becoming decompensated, and we add that later on for just record's sake. But you know, the key events that we're looking for during rapid response is just what is happening right there and then, and what did we provide to that patient.
Great. And I'll just point out that the point of documentation is really good communication, because oftentimes when a rapid response team is called, sometimes the patient is stabilized and they stay in the ward and they stay with the care they were receiving. But other times they are escalated to a higher level of care, whether that's a different ward, going to the ICU, or even transferring to another facility. So the point of good documentation is really good communication so that the patient is safe and that the patient receives the best level of care for them moving forward after the RRT. So I'm going to move quickly now because we have 3 minutes left. So I want to just say that I am honored to have worked with these amazing panelists. And I really want to just say thank you so much for the time that you've dedicated to this. And in the last minute or two, I'm just going to run through how, for those 50% of us that do not have a rapid response team, how would we implement that in our hospital? How can we increase the safety and care for our patients? And so the implementation of a rapid response team should really fall under identifying the situation. So the rapid response system may improve patient outcomes. So this is kind of why we would want to do this. It may identify the early warning signs before the patient arrests. So you can actually stabilize the patient so they don't have to have a code blue called. And rapid response systems provide time-critical care to unstable patients. I liked the statement by Rodrigo and by Sean that critical care is really time-critical care, and that we're really bringing critical care to the bedside. I think those are two of the best statements that were really made today. You want to evaluate what's happening in your facility, and then you can identify the gaps. So you want to create an RRT policy document for your institution. You want to identify the key stakeholders, whether that's patients, nurses, physicians, families, pharmacists, respiratory therapists, all of those. And then you want to really spend some time identifying the barriers. Why do you not have a rapid response team, and what are going to be the challenges to implementing a rapid response team? Then you need to make the decision. You need to form a committee, ensure that you've talked to and involved all of the key stakeholders, and also get their perspectives and what they see as barriers so that you can overcome those barriers. And then establish a timeline from which you're going to institute or make these changes, and identify any solutions that you can to the barriers that were identified. And the final step is to take action to adapt any existing protocols to your institutional resources, and ensure that you have scheduled reviews of the policy and the program so that you can continuously improve on the policies that are there, or continuously reassess how effective they are. And then finally, you need to institute simulation and practice. And if you see that this is a clickable link, and it will take you back to that team steps that has those example scenarios. And I'll let Dr. Rodrigo just make one final statement on why simulation is important in these types of things.
Well, simulation is the only way that we can train human factors. You cannot read about them. The only way that we can practice leadership, communication, and all that skills are doing simulation. And you don't need to do it a very expensive way. You don't need to invest a lot of money in a simulator. A lot of simulations can be done with an actor in just the real setting. So you can implement a very good simulation program with very low resources. So I think it's fundamental, it's critical to have simulation.
I agree. Thank you so much. And for the participants, when you go to the Learning Resource Center, there's some next steps for implementation of your own rapid response team. And again, I want to say thank you to our partners, to Assist International, to Project ECHO, to Stanford Anesthesia, to the WFSA, and to all of my amazing colleagues on this panel and all of these participants. I'm not sure if you realize, but we have participants from over 128 countries and we're reaching thousands of people. So this is an amazing group of people and I feel honored to work with you. So thank you all for joining us and thank you for your time.
Thank you, everyone. I just have a couple of notes from on behalf of Assist International. Wow, what a wonderful session. To close off, I would like to extend a big thank you to all of our incredible panelists for sharing their time and expertise with us today. Would not be possible without you. We're also thankful to all of you who are calling in today from around the world and actively participating through the chat and through the polls. Thank you so much for joining. And of course, we also would like to thank our funders who make this program possible, and that is the Project ECHO Institute and the GE Foundation. So on the slide, you can see a couple of follow-up notes. I've shared a number of links in the chat, but these will all be shared by email after the session as well. A number of people asked for, slides, resource links, etc., etc. Those are all available on the Learning Resource Center. The site also includes many additional resources, quizzes, case exercises, and videos. Recordings will be posted in the next 1 or 2 days and also shared by email. And then to obtain a certificate of attendance, you are asked to fill out a short feedback survey on the program that we use to continuously improve our program. This survey is available in multiple languages and it's been posted in the chat. So thank you so much everyone for your time today. If you have any other questions, please email us at echo@assistinternational.org. Bye.